My name is Dr. Richard Nowak. I'm an associate professor of neurology at the Yale School of Medicine, Yale University. I direct the Myasthenia Gravis clinic at Yale, and I'm also the director of the program for clinical and translational neuromuscular research. So myasthenia gravis is a condition that is considered rare in that there's about 80 to maybe up to 100,000 Americans with this condition. It's an autoimmune condition. For many years we've had very broad immunosuppressive therapies, including corticosteroids, with a high burden of disease. In about a decade or so, we recognized that approximately 15 to up to 20% of individuals were what we termed medically refractory. So there was a need to develop new medications to take care of patients, especially those that weren't responding very well to the conventional immunosuppressive therapies, or were potentially having a high burden from those therapies, including burdens from corticosteroids. The targeted therapies that became available to us came from many years of research in this area, understanding the immune system and trying to target specific parts of the immune system that were important to disease. Yeah, the treatment paradigm is evolving. So for many years we've used the conventional immunotherapies, but as the therapy landscape evolves, we have new targeted treatment strategies. And I see these as falling into three major buckets at this point in time in terms of the targeted therapies or the biologics. The first being complement inhibitor therapies, the second being FcRn antagonists, and the third potentially being targeting B-cell or B-cell depletion therapies. The decision as to which to choose for which patient is very nuanced. Sometimes the decision is dictated based on the autoantibody subtype. So for instance, acetylcholine receptor antibody disease is immunologically different from MuSK antibody disease, and understanding that element of it helps determine which treatment strategy might be beneficial for that patient. So for instance, in MuSK-MG, complement inhibitors would not work, as MuSK-MG is an IgG4 mediated disease where there isn't believed to be a role of complement in the immunopathology. So MINT, which is Myasthenia Gravis Inebilizumab trial, was a phase 3 registrational trial that looked at Inebilizumab in patients with either acetylcholine receptor or MuSK antibody positive disease. It was a placebo-controlled clinical trial, multi-center, global, that randomized patients one-to-one to either Inebilizumab or placebo. And the primary outcome of that trial was to determine whether or not there was a reduction in MG-ADL score from the time of enrollment to week 26. So what's unique about Inebilizumab is that it represents a unique mechanism of action in that it targets anti-CD19 positive B cells. And why might that be important, and why might we want to consider that? It's because those are the cells that actually produce autoantibodies. So that is where the factories of autoantibody production are. And that makes it unique if you compare and contrast it to some of the other targeted therapies out there. As mentioned before, the other two buckets of targeted immunotherapies in myasthenia gravis are FcRn antagonists, where they just simply lower antibody levels, IgG, or C5 complement inhibitors that block complement, but they don't actually address where the factories of antibody production are that then lead to the immunopathology of this disease. So it's targeting the upstream immunomechanisms of generalized myasthenia gravis, in the case here of acetylcholine receptor and MuSK antibody positive myasthenia. Findings demonstrated that in the combined population of AChR and MuSK antibody positive patients that there was a significant reduction in MG-ADL score in the Inebilizumab arm as compared to the placebo. So in the end, the primary endpoint or outcome was met for the study. So the study was positive. It also further demonstrated safety and tolerability. Inebilizumab is approved for another indication. The safety and tolerability profile was as expected and as demonstrated previously. So no surprises from that perspective. So safety and tolerability were again demonstrated in a myasthenia gravis population in MINT. I would say that based on MINT, we have evidence in support of the role of B-cell depletion therapy, specifically anti-CD19 B-cell depletion therapy for generalized myasthenia gravis. One of the important pieces of our MINT trial design was that it included a protocol-specified prednisone taper. Many patients with myasthenia gravis are on corticosteroids, specifically prednisone, and this treatment has a high burden in that there's a number of different potential side effects that can emerge. As part of MINT, we made a decision to decrease those prednisone doses or taper the patients after week 4 to try to reduce that burden. So even in the setting of steroid dose reduction as specified by the MINT protocol, we observed differences in the MG-ADL scores between the inebilizumab versus the placebo group. So this is really important, as other clinical trials that have studied different agents did not do that. So this is really unique and a differentiator as part of our MINT study. What I would additionally say is the following. The treatments with inebilizumab are not very frequent in that patients receive treatment initially, and then they receive their second infusion 2 weeks later, and then they're not due for another infusion until 6 months. So it's a medication that is dosed once every 6 months, and that also is very important and unique. So the burden of treatment with inebilizumab is also reduced as compared to some of the other agents that are available and used in the treatment of generalized myasthenia gravis at this time. I think raising awareness about MINT is critically important. What we presented at the AANEM this week was the top-line results. So future directions include preparation and publication of our primary manuscript to have that in the medical literature, and to continue to bring to the attention of the community physicians the results of MINT. So more information to come over the coming months and into 2025.